I am Dr. John Stone, the Executive Chairman of the IgG Forward Foundation. It's a great pleasure to welcome you all to our first webinar or fireside chat of 2025. For all of 2025 so far, we've been playing a lot of our JAM content. Actually, going back since mid-December, we've been airing different parts of our JAM content, and I know you've enjoyed all of that. But it's great to do a live fireside chat today, and I am delighted to be joined by Kevin Walton, who is back by popular demand. Kevin gave a wonderful breakout session at the JAM, and we thought it was worthwhile to have him here to do a live fireside chat. So I'll say more about Kevin and welcome him in just a moment. I want to start, of course, with our IgG Forward mission statement. Our mission is to enhance lives through education, awareness, and research, and to serve as a trusted source of truth for people living with IgG4-related disease. A couple of announcements to begin with. We're not quite through with our JAM content. There are two more JAM components that we will be airing soon. These are both from breakout sessions that needed some post-production editing to heighten their production values. And so the first is IgG4-related disease in the kidney. I know a lot of you are waiting for that. We wanted to tweak it so that it would have the maximal educational input or impact. So that is with Dr. Saif Al-Anisi, and we'll give you adequate heads up before airing that. And then the last component of our JAM content is the less common manifestations of IgG4-related disease with Dr. Guy Katz. We just got the video cut of that today, and we'll let you know when that's going to be airing as well. So both of these are coming soon. Want to give you a quick overview of the fireside chat topics for this year. So this schedule is a little bit fluid. We love the titles. We're not fully committed to the precise dates, but we'll be having one of these about every 4 to 6 weeks. So we'll start today with eating well with IgG4-related disease. We will speak soon about pancreatic and bile duct disease. April 4th is IgG4-related disease day. And what we intend to do on this day is have our Hope is Here talk. Hope is Here was actually scheduled to be the sort of last talk at the JAM, and we have held some of that in reserve for a very special day, namely IgG4-related disease day. So look forward to that. Mark that on your calendar as a red letter day. Then we'll have our first of 2 caregivers conversations of this year, led by Catherine Provencher. We will talk about retroperitoneal fibrosis. In the late summer, right before the virus season, we will have another session on vaccinology for people living with IgG4-related disease. That was a very popular session last year, and it will be important to do that again this year. And then we'll have a second caregivers conversation as well. Again, these titles are somewhat fluid. If something really hot comes up, we could swap in, or maybe we would just add another one. So watch our website and our online community for any changes. Couple more announcements. Very excited about this. IgG4Me is an app that the foundation is partnering with a company called MeJo, which stands for My Journal, to develop. This IgG4 specific app is directed to patients and their caregivers, and it will help them keep track, chart the various elements of their care, their medications, their essential labs, their doctors' names and contact information. And we'll be having a special session at some point to roll out IgG4Me, which is the name we have decided upon for this app. It will probably roll out during Rare Diseases Week, which is the last week in February. So coming up in just 3 or 4 weeks, IgG4Me will be ready. We've been working very intensely on that for some time now, and we're excited to roll it out. Second is you will have received last week, I think it was last week, a survey. We would love to have your input about where we are now with IgG4, with IgG Forward and our website and the other educational content and other services that we strive to provide. So whether you are a person living with IgG4-related disease, a healthcare provider, a caregiver, a friend, or family member, there is an element of the survey for you, also for industry people. So there is an element of the survey for all of you. It's a very short survey. It has 8 to 10 questions, and we very much value your input. So before I introduce Kevin, I wanted to take the opportunity to answer 2 burning questions. These are questions that we hear again and again. We see them in the online community. We hear about them online, and we really thought we should take this opportunity to answer these questions. Now, one of the most important questions that we get, Kevin's going to address today, and this relates to diet and IgG4-related disease. But there are 2 other burning questions, and I want to start quickly with those. So the first is, what is my life expectancy? Now, the importance of this question, the urgency of this question was driven home for me by a comment that we had earlier this week in the online community. And it was posted by a patient who has orbital disease. This is not his CT scan, but it is a representative CT scan of a person with IgG4-related orbital disease. It's a cross-section, a CT, through the orbits, through the eyes. And so one can see the 2 eyeballs here. And the black arrow is pointing to a mass, a large mass. So this is orbital disease, which can take a number of shapes in IgG4-related disease, but this is a pretty classic presentation. This person was just diagnosed with IgG4-related disease and had, as is predictable, a very long journey to diagnosis and has a lot of questions about what this means. But one of the important ones he asks is it true that you only live 20 years after being diagnosed? I am so thankful to this patient for posing this question and giving us the opportunity to answer it. Is it true that you only live 20 years after being diagnosed? This is completely and utterly false. And I think that Mark Twain actually gives us the best framework for understanding this. He said, there are 3 kinds of lies. There are lies, there are damned lies, and there are statistics. Now, I don't think that this rumor about patients living only 20 years after the diagnosis of IgG4-related disease is a lie or a damned lie, because in order to be a lie, the person who has said it really has to know that it is not true and to willingly say something that is false. This falls into the category of a statistic, and Twain was rightfully suspicious of statistics. So we were able to track down the source of this, and thank you to Catherine Provencher for tracking this down. She found this on the web. Now, it is under, if you search Dr. Google, you'll find that it is under some information that was posted by the American College of Rheumatology, which is a reputable source. And indeed, I helped them develop this first part of it, which is very short and doesn't say really very much that is helpful with regard to IgG4-related disease, but at least it's not factually incorrect. But then if you look down a little bit further, you see people also ask, what is the life expectancy of someone with IgG4-related disease? This is not ACR, American College of Rheumatology content. I have no idea where it came from. But if you click on that, you will see what is the life expectancy of someone with IgG4-related disease. Because the median age of onset is 58 and the clinical symptomatology is relatively mild, that is certainly not always true. With slow progression, that's often the case, and a good response to steroid therapy, partly true. Life expectancy after diagnosis was estimated at 20 years. I have no idea where they got that, but if you think about it, and I searched this morning on what life expectancy is in the United States, in 2022, the life expectancy was 77.4 years. And the blue curve here shows life expectancy in the United States. It's been rising since 1960, a little dip here around the time of the pandemic. And unfortunately, in the United States, we lag a little bit behind Canada and the UK in terms of life expectancy. But if you subtract 58 from 77.4, you get 19.4, which is about 20 years, which is, I think, where this came from. So it is very important to understand the source of this and the pitfalls in its logic. So, a summary of the answer, and I want to state this very unequivocally. Is it true that people with IgG4-related disease live on average 20 years after the diagnosis? This is absolutely false, wrong. It is a misunderstanding of information. What I tell my patients, such as I told this 26-year-old woman who was in fact my very first patient with IgG4-related disease, if you're 26 years old or 36 years old and you are diagnosed and you are treated appropriately and you are managed carefully and followed wisely, you will know your grandchildren and your great-grandchildren, and this disease will not shorten your longevity. And that is true for patients of any age, regardless of their diagnosis. If the disease is diagnosed and managed appropriately, it should not shorten your longevity. So keep that in mind and be reassured by that. And as we know more about IgG4-related disease, we will happily confirm that in a series of longitudinal studies. The second question that is so common is IgG4-related disease a genetic disease? The simple answer is no. When you're asked this, you should just say no, because that is the simple answer. It is the correct answer, and I'll explain why. So tell yourself that, tell friends and family members that when asked. The answer is no. So what is a genetic disease? A true genetic disease. So Huntington's chorea is an example of a true genetic disease. Huntington's chorea is a neurodegenerative disease that is caused by the presence of a single gene. Woody Guthrie, great American folk singer, wrote "This Land Is Your Land," had Huntington's chorea. If you've seen the current Bob Dylan movie out called The Complete Unknown, Woody Guthrie plays a role in that. So Guthrie unfortunately died of Huntington's chorea, and in the movie he's shown dying of Huntington's chorea. Huntington's chorea is a genetic disease that is associated with autosomal dominant inheritance. That means if one of your parents had this disease, you have a high likelihood of getting the disease. In fact, theoretically, you have about a 50% chance of having Huntington's chorea if one of your parents had it. Arlo Guthrie, Woody's son, who's also a famous folk singer, has not developed Huntington's chorea, and he is well into his 80s now, I think. So he didn't get this gene. Two of his sisters did, unfortunately, and two of his sisters died of Huntington's chorea. So Huntington's chorea is one of the diseases we think about when we think about a genetic disease. The other example that I would tell you about is Down syndrome, which is a syndrome that we're all familiar with. So Down syndrome is caused by trisomy 21, which means that the person has 3 copies of chromosome 21. So rather than having 46 chromosomes, as most humans do, patients with Down syndrome have 47 because they have 3 copies and not only 2 of chromosome 21. And trisomy 21 is a trait that is associated with high penetrance, meaning that if a baby in utero has trisomy 21, 3 copies of the 21st chromosome, then that baby is going to be born with Down syndrome, 100%. So Down syndrome is another classic disease that is a genetic disease. IgG4-related disease is different from these. So IgG4-related disease is what geneticists call a complex trait, and which means that it's not only one gene that is associated with it or one chromosome. It's a complex trait, meaning that genetics probably play a role in this to a certain extent, but it is actually quite small, far smaller than with Huntington's chorea or Down's syndrome. It is similar, perhaps, to other diseases that we often consider to be autoimmune or are autoimmune: rheumatoid arthritis, lupus, Crohn's disease. These diseases clearly have a genetic component, and I believe that the genetic component for those diseases is likely substantially higher than it is for IgG4-related disease. It's known that hundreds of diseases, hundreds of genes, contribute some risk to these diseases. Very, very small amounts of risk for each of them. But there are other components of these diseases, a risk for these diseases, that we do not understand. And I actually think there's probably something special about IgG4-related disease that makes it a little bit different from these others. And the genetic contribution for IgG4-related disease is probably substantially smaller. So genes are not the major risk factor for IgG4-related disease. And when you think about it, familial cases are very, very rare. So it's not like Huntington's chorea, where your child has a 50% chance of having the disease if you've got that gene. Out of the 1,000 or so patients with IgG4-related disease that I've seen, I've only seen one instance of a familial case, a son and then a father who developed it after the son did, and very different clinical features. So in answer to the question, IgG4-related disease is not a genetic disease. And the upshot of that question, the reason people are so concerned about it, is your children are not likely to get IgG4-related disease. So I hope I've been clear enough about that second burning question. You can expect to see these reprised on our website in other forms because they do tend to come up again and again. But without further ado, I want to welcome Kevin Walton. Kevin has been a revelation for me since I invited him to speak at the JAM. Yasmin Barco Hernandez, who was a pancreatologist at MGH, recommended Kevin when I said we need a good dietitian to come and speak at the JAM. She recommended Kevin. Kevin has been at MGH for 3 years. He was an undergraduate at Johnson and Wales University in Providence, Rhode Island, where he studied culinary arts. Then he did a master's in the science of human nutrition at the University of New Haven, followed by an internship at down at Danbury Hospital in nutrition. So, Kevin, it's wonderful to welcome you. Thank you so much for joining us and sharing your expertise, and I'll turn it over to you.
Yeah, I just wanted to say thank you so much for having me, you and the foundation again. I'm happy to be here again. Hopefully, we'll talk about some good things. At the end, we'll answer some of the questions everyone submitted. But again, I'm really happy to be here again, and thank you.
Thank you for
So, for
joining.
some overview, we're going to talk about the relationship between IgG4 related diseases and nutrition, some of the major nutrition complications, some nutritional monitoring, essentially things to kind of keep an out for if you have a diagnosis, if you have certain organ involvement, again, just kind of things to keep an eye on. We'll be talking about some action steps, some things that patients can do who have a diagnosis of IgG4 related diseases. We'll break it down into some specific organ systems. Um, I will give particular focus to the pancreas just because of its relationship with nutrition and how closely related the pancreas and nutrition are. But I'll also be talking about a little bit in terms of renal involvement and those with salivary gland involvement as well. And then at the end, we'll wrap it up with some of those questions that were submitted. And yeah,
And Kevin, I forgot to say exactly what your role is at MGH. You work as a nutritionist on a very complicated service. The surgery service, the GI surgery and trauma surgery unit. You also have an outpatient clinic in which you work with gastroenterologists, including Dr. Barco Hernandez, seeing patients with IgG4-related disease. So dealing with a complicated group of pancreatic and biliary tract diseases.
yeah, I would say my most seen patient population are those inpatients on like a we call it a surgical trauma or surgical GI floor. A lot of these patients have resections in their gastrointestinal tract, whether it's Crohn's or ulcerative colitis or a host or other like blunt traumas. But in the complicated pancreatitis treatment center, we see a whole range of very complicated pancreatic disorders, working alongside some gastroenterologists and surgeons, just kind of like a one-stop shop for these patients who have complications and complicated diseases relating to their pancreas. Just give kind of all-encompassing care. But yeah,
So you're used to tough cases, working with our surgeons. That's the
definitely my favorite.
way it is. Okay.
So just to talk about some abbreviations, there'll be some here and then we'll review some as we go. But AIP would stand for autoimmune pancreatitis, one of the complications if someone has pancreatic involvement. EPI would stand for exocrine pancreatic insufficiency. And then PERT or pancreatic enzyme replacement therapy. These are all things that we'll explain a bit more as we go.
And I would really love it if the IgG4-related disease community becomes comfortable with these abbreviations. EPI, especially if you're a person living with IgG4-related disease who has pancreatic involvement, then EPI is an important concept to know about, as is PERT.
Yeah. So talking about IgG4 related diseases and nutrition, I'm sure Dr. Stone can comment on this. The frequently impacted organs are typically the lacrimal glands, the major salivary glands, the retroperitoneum, and the pancreas. But other organ systems can be affected, like the thyroid glands, hepatobiliary systems, and the kidneys. The brunt of this talk will be talking about the pancreas, the kidneys, and the salivary glands. But what's really interesting is the nutrition implications are really dependent on the affected organ system. So, for example, if someone had pancreatic involvement and not really any kidney involvement, they wouldn't need to quote unquote worry about the nutrition implications regarding to the kidney. So, really, the nutrition recommendations and considerations are specifically related to the organ that is involved related to the IgG4 related diseases. I would say the most nutritionally relevant organs are those of the pancreas, salivary glands, and less commonly the bile ducts in the kidney, just because of how closely they are related to someone's nutrition.
So one size doesn't fit all, not surprisingly, when it comes to IgG4-related disease. And it's really important to understand one's specific diagnosis and organ manifestations carefully and those implications, and to learn from nutritionists like Kevin and other experts.
Exactly. Like if you had involvement in your eyes and no signs of involvement in your pancreas, you wouldn't really need to worry on a day-to-day basis in terms of the nutrition considerations with the pancreas, which we'll talk about more here. So one of the common complications with IgG4 related diseases with pancreatic involvement is that of autoimmune pancreatitis. Technically a form of chronic pancreatitis. Typically, it's treated with steroids or glucocorticoids. Rates of relapse can be high, but it's kind of the most common insult or, yeah, insult, if you will. Um, with pancreatic involvement, one of the other things that could go astray is that of exocrine pancreatic insufficiency. There's that EPI again. Some signs and symptoms of that are unintentional weight loss, some malabsorption of macro and micronutrients, potential malnutrition, osteoporosis or weakening of the bones. It might affect your quality of life negatively. You might have a decreased functional status, maybe not being able to do all the things you once were able to do, go shopping, take stairs, hanging out with friends and family. So your quality of life may be impacted. Um, and how we assess for this, it's definitely multifactorial, but a common way to assess for this is something called a fecal pancreatic elastase. I'll expand as we go through the presentation, but an elastase is an enzyme made by the pancreas that we can test for in someone's stool, and it kind of gives us an insight to how well the pancreas is doing. So someone might have a pancreatic fecal elastase done. It's a stool sample sent in as opposed to blood work, just to kind of check in at how the pancreas is doing. But it's not the only thing in how to diagnose exocrine pancreatic insufficiency or EPI. For example, if someone did not have an elastase test done, but they had a host of these symptoms listed and they were started on oral enzymes and they had a positive treatment response, they were able to tolerate foods and their symptoms were improving, that in itself might be indicative of someone having exocrine pancreatic insufficiency, even though they didn't have this test done. But again, we'll talk about it a little bit more as we go. Another sign of pancreatic involvement of things going astray is that of endocrine dysfunction. So we're talking about exocrine and endocrine. These are the two main functions of the pancreas, the exocrine and endocrine dysfunction. Endocrine dysfunction is mainly referring to the risks or difficulties in regulating blood sugars that typically relate to the degree of fibrosis or injury, for lack of a better term, of the pancreas. That could also be a complication of long-term steroid use. Another word is essentially a form of diabetes. And sometimes in these patient populations, it would be considered pancreatogenic diabetes or diabetes 3C. We've always heard of diabetes 1 or type 1 diabetes or type 2 diabetes. This is a little bit different of a subset of class called diabetes 3C, just because of how the organ is involved.
And I wanted to insert this here. It is some data from the MGH Rheumatology Clinic, which underscores the impact of pancreatic damage in IgG4-related disease. As Kevin has mentioned, about 50% of patients with IgG4-related disease have pancreatitis, autoimmune pancreatitis. We're interested in the question of disease-related damage in our patients. So we put these data together for the most recent American College of Rheumatology meeting in November. This work was led by Guy Katz, so all patients included in this study fulfilled the 2019 disease classification criteria. 191 patients fulfilled this at the time. 50% of those had pancreatic involvement. And among those with pancreatic involvement, more than half of them had EPI, exocrine pancreatic insufficiency. So more than half of those with pancreatic involvement had major injury to their pancreas. And then almost half of them also had diabetes. So these two bits of data really underscore the importance of the impact of pancreatic inflammation in this disease. And also because Kevin's going to talk about it a little bit, I also note that 38% of the patients in our cohort with kidney involvement had chronic or end-stage renal disease. So the kidneys can also be impacted very significantly in IgG4-related disease.
I think if I could piggyback off of that last slide,
Sure.
I think it's interesting to note that in this example, like 50% of patients would have pancreatic involvement, but not all of those patients had exocrine insufficiency or diabetes. So just because someone has pancreatic involvement does not mean it's a writing on the wall that they will get EPI or diabetes, but it is a potential risk factor. Essentially, what I'm trying to say is it definitely seems like a spectrum of having involvement and then having complications from that involvement.
I'm glad you added that in because it reminds me to say that the exocrine pancreatic insufficiency can be is widely underdiagnosed.
Mhm.
Patients don't know they have it. Doctors don't even know to think about it
Yeah,
in the patients. But if the patients have lost a lot of weight without another explanation, 30, 40, 50 pounds,
yeah.
they almost certainly have exocrine pancreatic insufficiency and it needs to be checked for.
So kind of shifting gears and talking about some monitoring things, and this is still within that pancreatic involvement arena, if you will. One of those things is that of the exocrine dysfunction. So one of the jobs of the pancreas is this exocrine function, which is referring to the pancreas's ability to make digestive enzymes that help us break down the food we're eating. So if that's kind of going astray, if someone has pancreatic involvement and they're developing exocrine dysfunction, those signs, just like Dr. Stone was mentioning, a lot of them, a lot of the big ones are unintentional changes to your weight. If you're doing your normal thing, living your normal life, and you're noticing unintentional weight loss that's picking up steam, that is not corrective to anything you're doing, that could be a sign that something's going astray. Another sign is something called steatorrhea. It's essentially, I describe them to my patients as wacky bowel movements. They might be foul smelling, they might be greasy or oily appearance. Like it might look almost like oil in the toilet bowl. They might even be a yellow or a golden hue. They might float, and you might even see a residue in the bowl after flushing. For example, patients have described to me it's honestly hard to wipe, or when they flush the toilet, it takes them 2 or 3 times of flushing the toilet to really kind of clear the bowl because there is that oily film or residue. That's a sign that you're not adequately digesting specifically the fat in your diet. And again, something might be going astray. Additionally, if you're having unexplained changes to your hair, nails, skin, or eyes, and that also might be an additional sign that something might be going astray, specifically relating to some micronutrients. The most common ones are the fat soluble vitamins A, D, E, and K. Kind of putting this all together, if someone's having unintentional weight loss and these wacky bowel movements, they might be malabsorbing these fat soluble vitamins that could result in changes to your hair, nails, skin, and eyes, unexplained changes. But additionally, someone's parathyroid hormone might tip a healthcare provider that something's going astray, as well as zinc, B12, iron, and folate.
So what kind of changes do you see in the nails?
Yeah, sometimes it's the spooning of the nails could be indicative of an iron deficiency. Certain lines in the nails, if they're very brittle, that could be a zinc or potentially again an iron deficiency. If they're not growing, in terms of vitamin A, people complain of changes in their eyesight. A common symptom is it's termed night blindness, but a lot of us can't see in the dark, but it's a heightened sense of I really can't see in the dark. Vitamin D is more relating to someone's bone health. That vitamin D and the parathyroid hormone in conjunction can give us a look at someone's bone health, in addition to something like a DEXA scan. Vitamin K is a little harder to diagnose because it's more related to someone's blood coagulation. Um, B12 and folate, you might see some changes in someone's complete blood count or their hematology in terms of types of anemia. Um, but broadly speaking, any unexplained changes in your hair, nails, skin, and eyes in combination with these other symptoms just warrants further investigation.
Okay.
So on the other side, we have exocrine function. The other job of the pancreas is that of the endocrine function. If something's going wrong in terms of the endocrine function, A really good lab test is something called a hemoglobin A1C. That's that kind of 3-month diabetes number. That, in layman's terms, it's a 3-month average of the blood sugar that's attached to your red blood cell. It's a very helpful long-term trending value, just to evaluate the function or the healthiness of the pancreas in terms of the endocrine dysfunction. But if you've never had an A1C, if you're experiencing things like frequent urination, excessive thirst, again, unintentional weight loss, or blurry vision, those are all signs of chronic hyperglycemia or high blood sugar that definitely warrants pretty immediate evaluation and just reviewing with your healthcare provider. So in terms of action steps with those with pancreatic involvement that have EPI, or again, exocrine pancreatic insufficiency, in terms of a diet, I would say a well-balanced diet really goes a long way. I would say there is not a universal recommendation to limit fat in your diet. Say that again. If you have EPI, it is not broadly recommended to really restrict fat unless it is a very clear trigger. For example, if you're at a restaurant and you're having a very fatty steak or a very fatty pasta, and you notice you really did not feel well afterwards, and you kind of had some of those symptoms of that steatorrhea or those wacky bowel movements, but you didn't have those symptoms with kind of other normo fat meals, it just might be advisable to limit high fat foods as opposed to always restricting fat. So kind of person to person based on your symptoms and what you're eating. Having high calorie, high protein diets can be helpful if you're having difficulty with weight maintenance. What's really helpful with this is doing that by having smaller, more frequent meals instead of having that traditional 3 square meals a day. Let's say you're having your lunch and you can only eat half of it because of whatever symptoms. I wouldn't want you to not eat before dinner and have hours in between. It's totally okay to have more smaller meals more frequently. I would try as your best to get a source of protein in those small meals, but it can help your net energy intake. But a good way to help with that is something called an oral nutrition supplement, a fancy word for like a protein shake or an Ensure or a Boost or a Muscle Milk or a Fairlife protein shake. These are very helpful because they pack a lot of nutrition in a relatively small volume. For example, if someone's having a hard time tolerating large amounts of foods, these can kind of help fill in the gaps or supplement their intake, just to get enough calories to prevent this weight loss, to prevent unintentional changes to their lifestyle, etc. And here on the right's a good visual. This is what's called the My Plate. This is almost the new age version of the food pyramid, essentially. In a perfect world, your meals or your plates, if you will, should look like this. At least half of them fruits and vegetables if you can. A quarter of your plate should be at least whole grains if you can. A quarter lean proteins, while limiting foods that are high in sodium, simple sugars. And if you're having dairy, which definitely is encouraged, the lower fat options are a bit better. So this is just a visual in terms of what your plates might look like in a perfect world. Later on, I'm going to break this down into some specific food groups or like quotas, if you will, to maybe shoot for throughout the week. So again, those with EPI, here's the acronym again, that PERT, or that Pancreatic Enzyme Replacement Therapy. This can be very helpful and almost like a game changer, if you will, for those with exocrine pancreatic insufficiency or EPI. So going back to those wacky bowel movements, if you're having those somewhat frequently, if you're losing weight, you're just not having a good time, for lack of a better term, these enzymes can be very helpful. So one of the jobs of the pancreas is that of the exocrine function. If the pancreas is damaged and someone has EPI, that means they're not producing enough of these enzymes to help us break down our food. And taking oral enzymes, or PERT for lack of a better term, gives us the tools or enzymes to help us break down the food we're eating so we can adequately utilize it, as opposed to kind of us getting rid of it in a way that we hadn't absorbed efficiently. So if you're having excess fat in your stools or that steatorrhea, those wacky bowel movements, the unintentional changes to your weight, reduced quality of life, it would be reasonable to talk to your healthcare team about potentially even trialing them. I'll go back to that elastase I mentioned earlier. Again, an elastase is a helpful stool sample. It's a test to help evaluate your pancreatic function. But if you don't have access to that, it might be reasonable to work with your team to trial enzymes for maybe 2 weeks and see if you had symptomatic improvement. Generally, they're weight based and we up titrate from there. Sometimes it does take a little fine tuning, to be honest, but typically you'd be start at a quote unquote baseline dose. And if your symptoms improve, great, that dose might work for you. But if you're starting on enzymes and you're still having kind of these adverse symptoms, it might be worth up titrating or increasing the dose, again, while reviewing with your team, just to see if there's symptomatic improvement. How we take them is typically with your meals. So a lot of people take their morning medications and they're good for the day. These enzymes you're supposed to be taking with the food you're eating. In a perfect world, let's say someone were to take 2 capsules of enzymes. It's first bite of food, take the enzyme, same time. And then again, if you can, if you're taking 2 capsules, maybe take the second one halfway through the meal. If you're having a very light snack, let's say an apple, you might not need to take an enzyme. I would ask yourself if something has any degree of fat or protein, it would be reasonable to take at least one, depending on the size. On the other side, if you're going out to dinner for someone's holiday or someone's birthday or a holiday or some special event and you order a very decadent, very fatty, kind of like you're indulging for this special occasion, we're all human, it might not be a bad idea to take an extra one during this very fatty meal. But the goal is for you to take them at the same time with your meals.
Kevin, I'll share an anecdote that I heard in clinic this week. One
Yeah.
of my patients who lives out of town and has EPI came to Boston the evening before his appointment with me, went to the Celtics game
Mm-hmm.
and had a cheesesteak. And at 3 a.m. was awakened with pretty terrible abdominal pain. And this illustrated, it allowed me to illustrate for him the importance of taking PERT. I had had this discussion with him before and wanted him to talk with his gastroenterologist back where he lives, but for one reason or another, that hadn't happened.
Mm-hmm.
And do you suspect that if he had had his pancreatic enzyme pills in his pocket and taken those at the time he started his cheesecake, he might have slept better through the night?
I think it's a possibility. It really is almost like an all or nothing thing. If your pancreas is injured to the point where you have exocrine pancreatic insufficiency, you're not producing enough of those enzymes. So naturally, when you eat, let's say, a fattier food like a cheesesteak or cheesecake or whatever this person had, your pancreas is naturally going to want to help out and secrete as much of those enzymes as it can, which that kind of effort for the pancreas to produce and secrete those enzymes might be uncomfortable. But also, there might not be enough of those enzymes to help break down that fatty food, which could result in that pain, that bloating, that just very upset, unhappy GI intolerance that could have been lessened or avoided if he had enough of those enzymes externally, if they were taking enzymes. So I think it's a reasonable possibility.
And it's also important to note, I think, that these are simply replacing normal enzymes.
Yep.
So these pills don't have side effects, really. You can't take too many of them. You can't overdose on them. I think you usually recommend starting with 3 before each meal and then maybe add a 4th one if it's going to be a particularly fatty meal like a cheesesteak.
Yeah, I don't think it's a bad idea for sure.
Okay.
The So in terms of micronutrients, this is another action step you can do. If you're starting enzymes, it might be reasonable to ask or work with your team to kind of get a baseline set of micronutrients. Um, but if you're having unexplained changes to your hair, nails, skin, and eyes, just keep an eye on those. If you're starting enzymes and you're experiencing these symptoms, and there's a weird rash that you don't know where it came from, or you notice waking up in the morning and there's a clump of hair on the pillow, or you're washing your hair in the shower and you're noticing a hair thinning, just something to keep an eye out for. And these are those kind of vitamins or micronutrients I was talking about in terms of the vitamins and minerals. Our practice in the Pancreatitis Treatment Center is if someone's starting enzymes and we think it's reasonable that they will continue on them for somewhat of a long term. For example, if they're starting a 2-week trial, I might not want to check all these, but if we think they have significant involvement, that they'll be taking enzymes for a while, it might be helpful to kind of get a baseline of these labs, specifically vitamins, the fat soluble A, D, E, and K, but also minerals like zinc, selenium, magnesium. The parathyroid hormone is a hormone produced by the thyroid gland that sits right on the kidneys. That just that in conjunction with vitamin D helps assess bone health, as well as B12 and folate, iron studies. It might be helpful to kind of take a picture of this slide, bring to your healthcare team. We would encourage a CRP as well, which helps us measure the amount of inflammation in the body. Sometimes reading these vitamins and minerals labs can get very tricky without the context of inflammation. For I'll summarize quickly. If someone has a very large degree of inflammation and their CRP was incredibly high, the body might want to hide or reserve some of these, which might make a blood lab a little bit skewed, which is just why we include the CRP just for help of interpretation of the labs.
So we'll put these on our website so that people can refer to them easily. The entire video of this fireside chat will be on our website next week. And Kevin, I think I'll ask you to write an answer to a good question, which we post frequently, about exactly what tests should be done in patients with IgG4-related disease, particularly those with pancreatic involvement. This is important because I can guarantee you most rheumatologists don't know these.
And there's some questions that people submitted at the end that we'll use as an example to touch on these micronutrient type questions.
Yeah.
So in terms of, we're moving on to the action steps or things with those with pancreatic involvement. There's almost like a double-edged sword for risk of developing diabetes. So before we were talking about that exocrine function, here we're talking about that endocrine function. And there almost is like a double-edged sword for the risk. So on one edge of the blade, if you're having chronic or repeat episodes of autoimmune pancreatitis, your pancreas might get damaged or injured, and it just might not have enough healthy tissue to function as it normally would. And that affected or damaged or atrophied pancreas might not produce enough insulin. So that's kind of one way where someone might be at risk for developing diabetes. But then on the other edge of the blade, one of the common treatment modalities is steroids to help kind of quell the IgG4, or in this case, autoimmune pancreatitis. And one of the risks of long-term steroid use is a risk of diabetes as well. So it's both a complication of both disease and treatment. If your pancreas is injured enough to the point where it can't produce enough of that hormone insulin, that's one risk, but then also the risks of long-term steroids.
So one of the things that I have seen in patients with pancreatic involvement is that there's sort of a yin and a yang between the exocrine and the endocrine dysfunction. A patient may become diabetic early on with their disease, especially if they're on steroids. But then if the exocrine pancreatic insufficiency is bad enough, they lose weight ultimately. Mm-hmm. And if they lose a lot of weight, then their glucose tolerance tends to be better. But that's not the optimal way of improving blood sugar control. That's not what we're aiming for.
Yeah. So furthering talking about the endocrine function of the pancreas. So some action steps with those with endocrine dysfunction. I can't stress enough how helpful it would be to have like an endocrinologist as part of your team. Whether you're a PCP or whoever you follow with can get you a referral to an endocrinologist. That can be extremely helpful in terms of the medications, the lifestyle management, as well as devices nowadays. The old kind of way is pricking your finger to check your blood sugar. Nowadays, there's things called continuous glucose monitors. Those little patches sometimes people wear on their arms. That's a patch that kind of gives a continuous reading of your glucose. But the endocrinologist can help you with all things managing diabetes to make your life easier, to make it easier for you to manage. And it really goes a long way. You're kind of not at it alone. If you can, getting a referral to a dietitian as well can be helpful.
Very important.
I will be frank, in some places, depending on where you are, what insurance you might have, it may be difficult to get a referral. But typically, getting a referral for diabetes is one of the easier ways to get a referral. But nonetheless, it doesn't hurt to ask. If you're at your PCP or you're at your endocrinologist, it would be reasonable to say, can I have a referral to see a dietitian just to kind of have a all-in-one care team and you're not at it alone. But in terms of specific action steps in terms of diet, the recommendations really relate to the type of insulin you're on, if you're taking insulin, if you're taking only oral meds, if you're in the pre-diabetic range. So it really depends of what spectrum you are in terms of this endocrine dysfunction. And then but more specifically, the broader recommendations are as best as you can, limiting included added sugars, something like a sugar sweetened beverage. Those are sometimes juices, sodas, iced teas, lemonade, vitamin waters, Gatorades, things that have a lot of included added sugar. It would best be limit or choose diet alternatives if you can. Also limiting or avoiding a lot of refined carbohydrates. I think something that goes unnoticed is it would not be recommended to avoid long gaps in your meal or snack schedule. I've had patients say they try to manage their diabetes by just not eating, because if I don't eat, I have nothing to raise my blood sugar, which is good for me, right? It's unfortunately not the case. If you're going long stretches, let's say 8-10 hours without eating to try to manage your diabetes, your body is naturally going to say, I need that energy. And it's going to look internally for that energy, which will raise your blood sugars anyway. So going long gaps without eating might result in a very high peak and a very low low and a very high peak, which just isn't the best. So having, we call it like a consistent intake of carbohydrates can be helpful, but also incorporation of more complex carbohydrates, which again, we'll talk about on some later slides and give some examples. I think a nutrition fact or like a food label really goes a long way. This kind of gives you the guide of all things EPI, endocrine, exocrine dysfunction, high calorie. It gives you the roadmap. It gives you the answers, for lack of a better term. And I highlighted just some key slides, or I highlighted some key points, if you will. The serving size is kind of the key here. If you're not following the serving size recommended on the package, all of this information is kind of gone to waste. For example, whatever this food is, if you're having double the portion size or serving size, you would have to double all of these numbers. So the portion size, it does really matter. For those, if you're having intolerances or GI upset to higher fat foods, I would want your eyes to look at that first bolded, that total fat in grams. That kind of gives you a guide of how much fat it is. The sodium can be helpful as well to determine how almost nutritious a food is, or I'm hinting at, we'll talk about kidney disease or kidney involvement a little bit later on. The carbohydrate, which isn't highlighted, but it's in bold, that's where you would look to see how much carbohydrate a food has. And if you see how the dietary fiber, the total sugar, and included added sugars, those are all indented and not in bold. That means they're included in that bolded total carbohydrate. So for example, if something had 0 grams included added sugar and 0 grams of total sugar, that is great. I think that's excellent because you're limiting those added sugars that you might not need, but it would still contain carbohydrate. Sometimes those words get a little mixed in terms of sugar and carbohydrate. So just because something might be sugar-free, it likely still contains carbohydrate. So I typically direct people looking at that bolded total carbohydrate and that indented, that double indented, included added sugar. And then there, the protein at the bottom is helpful just to assess how much protein it is. So moving on from the pancreatic involvement to some secondary nutrition implications. Like Dr. Stone was mentioning, right around maybe 30% of the patients with IgG4 might have some involvement in their kidneys. The recommendations for kidney involvement or kidney disease are a little bit more nuanced, so I'll try to be as specific as I can. I would say the biggest risk factor and the biggest key is controlling hypertension and diabetes if you have these coexisting diagnoses. So for example, if newly diagnosed IgG4 with kidney involvement, and you also have an existing diagnosis of hypertension, you addressing and managing and improving your hypertension will only help the kidney involvement with IgG4. And the same goes for diabetes, whether that's following with an endocrinologist, a dietitian, etc. The better you control your hypertension and your diabetes, the easier the easier of a load the kidneys get. If you were told you have quote unquote early kidney involvement, I would consider aiming goal protein intake for around 0.8 to 1 gram of protein per kilogram of body weight per day. This is a relatively easy equation, if you will. If you just go to Google and type in your weight in pounds and convert it to kilograms, that would be around how much protein you should be getting as a reasonable goal. If you're told you had early kidney involvement, or you're in the early stages, I would avoid going more than 1.3 grams of protein per kilogram a day. So just take your weight in kilograms and multiply it by 1.3. That would kind of be the upper limit. I would be weary about going above on a consistent basis. If you went above that one day, nothing's going to happen, but on a consistent chronic basis, just might stress the kidneys out a little bit. And here on the right, I have some conversions. I will be frank, it does take a little time and get used to measuring the amount of protein, grams of protein in the protein foods you're eating. I can't say enough how much far a digital scale, or again, reading the food labels can go. For example, one egg is around 6 to 8 grams of protein, or 1 ounce or 28 grams of animal protein. Like meat, poultry, fish, seafood has around 6 to 8 grams of protein. So for example, if you have a chicken breast with 4 ounce chicken breast, you can calculate the amount of protein and kind of compare it to that general goal of around 1 gram of protein per kilogram a day.
So the typical female is say 60 kilograms. So how much protein would a woman who weighs 60 kilograms take, ideal if she has early kidney disease?
In a perfect world, right around that 60 grams, I think is relatively reasonable, because you would aim for 1 gram of protein per kilogram. It's a 1-to-1 ratio. Again, if you go slightly over that, it's okay. But if you're consistently going above 1.3 grams of protein per kilogram, it just increases the risk of stressing out the kidneys a little bit too much.
Okay, so 1 gram per kilogram.
Right around there. Even if you want 1.1 or 1.2, it should be fine. But the concern is higher protein diets, which would be over that 1.3 grams per kilogram on a very consistent, long-term, chronic basis. If you do that once a week or a couple times a year, it all kind of comes out in the wash. But the concern would be like a chronic overstressing of the kidneys. There are a lot of apps that can be very helpful to track this. Like MyFitnessPal is a common one, or Calorie King. There are like apps on your phone that have almost barcode readers. Like you can scan a label and then it auto-populates the information. You can easily type in 4 ounces chicken breast and it'll pop out the protein. And so it's a good way to track. Again, it could be a little bit of an adjustment at first, but once you kind of get a feel for it, eyeballing it gets pretty easy. Another thing with kidney involvement across all stages, whether it's early or quote unquote late, would be limiting your amount of sodium you're having. I would try to get less than 2 grams or 2,000 milligrams a day. There are some recommendations of as long as you're having less than 2,300 milligrams or 2,300, that should be okay too. But I think it's reasonable to aim for 2 grams. And if you go a little over, you kind of have that buffer. Those apps I mentioned are also a very easy and nice and savvy way to track the kind of macro and micronutrients that you're taking in, just to kind of see what you're doing and how well you're doing, and maybe you need to adjust things. There's a nice little PDF here in terms of label reading. On the prior slide, we were looking at a nutrition label. This would be on the kind of the front of the package. Living in the Northeast, like Cape Cod chips are a very common snack in my household. And I picture myself at the store and I'm looking at different types of Cape Cod chips. I might see a green ribbon that says reduced fat, or for example, reduced sodium. So if something said reduced sodium, that just means it has about 25% less sodium. It's kind of hard to quantify that. But if something said sodium free or very low sodium, I know there's less than 35 milligrams of sodium per serving, which is a very reasonable choice. So kind of getting familiar with the terminology you might see on a food can be helpful. If you're told you had more advanced kidney involvement, you may need to limit certain minerals like potassium and phosphorus, but that definitely is a case by case basis. For example, all patients with end stage or late stage kidney disease, if they're on dialysis or not, sometimes their baseline diet might be very reasonable in potassium and they might not need to restrict. But for example, if someone's taking a lot of dairy that has a lot of phosphorus and persistently their labs have high phosphorus, the doctor, the nephrologist, the nurses are saying, Mr. Smith, Mrs. Smith, your phosphorus is persistently high. Then you might need to decrease the amount of phosphorus in your diet. And again, those apps and label reading really can go a long way to kind of track your phosphorus or potassium intake as some starting points.
This discussion really underscores for me the importance of consulting with a registered dietitian if you've got significant kidney involvement or pancreatic involvement. I think it's really an important component of care.
I would say that the kidney is very nuanced just because there are a lot of different factors at play. We're talking about protein, we're talking about sodium, we're talking about phosphorus and potassium and fluid. And it can get very confusing and frustrating to patients very quickly. That is extremely understandable and almost expected. And that's why I feel like the more kind of care team members of your care team you have on your side and the more resources you have at your disposal, whether it's friends with similar experiences or similar diagnoses, or apps like I'm mentioning that can kind of take the weight off of tracking. Nonetheless, it is an adjustment, but it's how can we make that adjustment how as have the most longevity and how we can make it stick the most because you'll only benefit in the end. So moving on, some other secondary nutrition implications. Salivary glands can have some involvement as well in IgG4 related diseases. So impaired saliva production may impact the palatability or enjoyment of the food, for lack of a better term. The comfort of eating, if your mouth is persistently dry, and it might be hard to chew and taste a lot of foods that might decrease your overall intake. Um, Also a risk for dental cavities. If someone's having persistent cavities and they're almost losing their teeth and they have, we call it poor dentition, that might impact their ability or limit the amount of foods they were eating. I have patients who, for whatever reason, they might have not all their teeth and they might not be able to eat fresh fruit, which can be a change in their kind of lifestyle. So the risk for cavities is worth noting as well. Some things to do that can be helpful. Sauces can go a long way. Like I think of like that typical steak dinner. Like gravy can be your friend to kind of help make it more lubricated, for lack of a better term. Cutting foods up in smaller bits can be helpful as well. Drinking liquids with meals can be super helpful. Just like, again, to help lubricate your mouth. Those times when you're not eating something like a lozenge or hard candy can go a long way just to kind of set your mouth up for that meal you're going to have. But also high calorie and high protein smoothies or shakes or those oral nutrition supplements can also go a really long way. There's so many brands nowadays. The most middle of the road is an Ensure or a Boost shake, but there are things like Orgain, which are a plant-based organic shake, Muscle Milk, Fairlife has a protein shake. There are pre and probiotic. Whatever works for you kind of works for me in terms of as long as you're able to get enough calories and protein and your weight is relatively stable. But protein shakes can go a long way. I would encourage you to even try protein powders. Similarly, there are a lot of different protein powders on the market, whether it's whey or milk-based or plant-based in terms of soy, or a common one is like pea, like the green pea protein powders. It's okay to experiment, and I would encourage it. I typically recommend patients getting a flavored protein powder and an unflavored. Get the smaller container at first just to see if you like it. The reason I recommend an unflavored protein powder is you can add it to the foods you're eating. For example, if you're making like a creamed soup or a casserole that's like very moist at baseline, adding unflavored protein powder is a really good way to fortify those foods without adding weird flavors. Like it wouldn't make sense to add chocolate protein powder to I don't know, cream of mushroom soup. That obviously doesn't work, but an unflavored protein powder may change its texture slightly, but it really fortifies those foods you're eating.
Okay, now we're on to common nutrition myths.
Yeah.
And then we'll move into summary and questions.
Yeah, so one of the common nutrition myths I feel like I hear on a day-to-day basis is blank supplement or mineral or substance will cure or fix my IgG4 related diseases. If I were to give a common and similar example, would be if I take vitamin C and zinc, I will never get a cold again. These are kind of common misconceptions. I think it's one thing to say, in this case, vitamin C and zinc are important in immune function and healthy immune function. But it's another thing entirely to say, taking blank supplement or taking zinc and vitamin C, I'll never get a cold again. I think those are two different things. So it's definitely very nuanced. Or another one is this food will reduce my inflammation. For example, apples will reduce my inflammation. Cherries will reduce my inflammation. Really, we can insert any food will reduce my inflammation. I definitely think it's a little nuanced. I would more frame it as certain foods have pro-inflammatory properties and anti-inflammatory properties. For example, foods that have anti-inflammatory properties, we think of those very dark, very colorful fruits and vegetables that have antioxidants. Or a common one is salmon with those omega-3 fatty acids, which are those healthy fats. So antioxidants and omega-3 acids do have anti-inflammatory properties, but it really is hard to trend how much it lowers it. And there's another question further on that I'll expand on this just a bit more. Another one is alkaline foods are better for you. Like nowadays, there's a water that's certain pH balance. I don't mean to be the bearer of bad news, but if we as humans were able to intentionally change the blood pH of ourselves, we would all have very bad and unfortunate demises. We cannot intentionally change our blood pH. A common example is a complication of diabetes or uncontrolled diabetes is something called diabetic ketoacidosis, or DKA for lack of a better term. If we break down that word, diabetic ketoacidosis, that acidosis is kind of the scary thing on my end. That is kind of hinting at someone's blood is too acidic, which is very dangerous and requires immediate medical attention and treatment and can be life-threatening if severe enough and untreated. And I think that's a good example to kind of drive it home of we cannot physically control or direct our blood pH. So if you're preferring a flavored water because the pH is different, it's likely not doing a lot. Your stomach is going to neutralize that whatever pH it was, but unfortunately it's a common myth.
Okay, we're on to quick tips now, and then we have a number of questions.
Yeah. I think if it's a good rule of thumb is if it seems too good to be true, it likely is. I think this is interesting that we're having this conversation today. I had a patient maybe 3 days ago who had some concerns with their bone health, among other things. And this patient asked me if he could be taking moose antler serum. I have never in my life heard of moose antler serum. This patient wanted to take it because of the proposed benefits of better bone health. And I think this is a good example of if it seems too good to be true, a blank supplement or substance will do something amazing. It likely is too good to be true. Another quick example is that of like memory supplements. I've seen plenty of commercials of blank supplement will fix your memory or prevent Alzheimer's. It's a lot more nuanced than that, and it could be too good to be true. I always talk about the difference between healthy and nutritious foods. I think healthy, it's hard to tell who it works for and when. What's healthy for me might not be healthy for you or your friends, family, etc. I think it might be helpful to reframe it internally as not healthy, but nutritious. If you're in the store or you're trying to eat something and you're asking yourself, is this healthy? Try next time, ask, is this nutritious? Because what's healthy for you might not be healthy for someone else, and vice versa. If you're choosing nutritious foods in terms of calories and protein and micronutrients, it's probably a good choice. I think portion control can go a long way, and I'll talk about that in a second, and balance. We're all human. We all like to indulge and have those unnutritious foods. See what I did there? But I think balance is really key. And generally speaking, what's right for you might not fit for someone else. Just because something worked for you or your friend might not work for you. And I think that's worth saying that. A common example is recently like the keto diet craze or intermittent fasting. If that works for somebody and their lifestyle and their ability to go to work and hang out with family and friends, etc., and that works for them, that's fine, as long as it's not obviously causing any negative health benefits. But there is no one size fits all approach, unfortunately.
Kevin, I think we should move to the questions now. There's some outstanding questions that were proposed
Let's do it.
in advance. And the first one is one of your favorite ones.
Hmm.
Some of the main manifestations of my IgG4-related disease are high levels of lipase and amylase in my blood and a low elastase in my stool sample. Should I be on a low-fat diet? So this is a patient with pancreatitis and probably EPI with the low elastase. Should that patient be on a low-fat diet?
Yeah, and reviewing all the questions that were submitted, there were a lot of great questions. I think this one resonated with me, and this one I think was my favorite. So whoever submitted it, props to you. Some quick definitions. Lipase and amylase are some of those enzymes produced by the pancreas, and normally they're secreted into the GI system. So they normally should be in your gut. But when we take a blood test in these labs, this lipase and amylase, they're too high in your blood. That's a sign that your pancreas is injured. They're kind of in the wrong spot in your bloodstream rather than your intestine. And your elastase we talked about is that enzyme in your stool. So should this person be on a low-fat diet? I would not recommend a universal low-fat diet. Following extremely low-fat diets might be harmful because you're missing out on a lot of needed calories, as well as it can be very unpalatable and very hard to navigate an extremely low-fat diet. What I would say to this person is just maybe pay a little bit more attention or be a little bit more mindful on the foods you're eating and how it affects you. If you consistently eat very high fatty proteins that you consistently feel poor, it just might be the fat in the protein, and more leaner options could be better. I think it would be reasonable to talk to your team about considering a trial of enzymes or PERT to see if that helps your symptoms. And you might not need to restrict fat, and you just needed that help from those oral enzymes to kind of fix the problem.
Okay. So this next question is, my IgG4-related disease was misdiagnosed as pancreatic cancer, and I suffered an unnecessary Whipple procedure. You can tell the audience what that is.
Yeah.
I feel that I have major nutrition issues because of the Whipple procedure. I'd like to hear your comments on nutrition in patients who've had a Whipple procedure. Unfortunately, we do see a lot of this, patients misdiagnosed as having cancer and having major surgery until the correct diagnosis is realized.
Yeah. One of the primary patients I work with, I'm primarily an inpatient dietitian, and the floor I work on, I would say the majority of the Whipples in the hospital at Massachusetts General Hospital, a strong majority of these patients come to my floor. I see patients with the new Whipples probably 3 to 4 times a week. Funny enough, I saw a patient who had a Whipple procedure just the other day this morning to talk about some nutrition considerations.
And a Whipple, just quickly, a Whipple procedure involves what comes out in a Whipple procedure?
Typically, it's resection of part of the stomach, part of the duodenum, which is the first part of the small intestine, and part or the head of the pancreas. And there's varying degrees of how much has to be resected. So we're talking about stomach involvement or stomach resection, small intestine or duodenum resection, as well as pancreas resection. Sometimes someone might have their gallbladder out at the same time, but that's a little bit more nuanced. So the question in terms of, I have major nutrition issues because of the Whipple. I would like to hear your comments on nutrition with IgG4 and a Whipple. There is a lot of overlap. When I'm talking to a patient with a new Whipple, they're newly status post to Whipple, I'm talking about the same exact things here with those with pancreatic involvement. When it comes to Whipple, they have similar risk factors and complications with diabetes, as well as exocrine pancreatic insufficiency or EPI. So the signs and symptoms and things to do are those of the exact same with IgG4 pancreatic involvement. So I think back to those kind of first handful of slides I talked about, those would be right up your alley and things to focus on. The Whipple does have some additional risks in terms of what's called dumping syndrome, depending on the type of Whipple you had, where a lot of included added sugars or too much simple sugars too quickly might not be well tolerated and cause very rapid onset of just kind of normal diarrhea. Um, Patients with a Whipple might have a harder time eating large amounts of portions. So a lot of the times when I'm counseling or working with people with a newly status post a Whipple, would be really focusing on those smaller, more frequent meals can really go a long way to fine tune your nutrition and really focusing on your protein intake. For example, if you're having a hard time eating large amounts and you're only able to tolerate small amounts more frequently, really making sure you have some protein at those mini meals can go a long way.
Okay. So I was diagnosed with type 1 AIP. That's the kind associated with IgG4-related disease 2.5 years ago. I'm on B-cell depletion treatment and therefore am immunocompromised to some extent. I also take PERT for
Mhm.
EPI. So this patient knows those abbreviations. That's great. My
Yeah.
question is, because I'm immunocompromised, how safe is eating unpasteurized cheese, fermented foods such as kimchi and natto, and uncooked vegetables within fat intake limits imposed by Creon, PERT? Is the risk worth the benefits?
Yeah, I look at this question as we're talking about risk benefits of someone who's immune compromised and just might be at increased risk for infection versus the health benefits that what this is commenting on, I'm looking at as almost fermented foods. I would say off the bat, I definitely would avoid all unpasteurized cheeses and milks just because of the risks. So whether someone's immunocompromised or not, I would recommend avoidance of unpasteurized dairy. But then moving on in terms of those fermented foods like kimchi, natto, sometimes sauerkraut, or um, like koji for certain populations or ethnicities. Um, so if we're talking about fermented foods first, it really depends on the type of immunocompromised you are. They're kind of very briefly a medication called Humira, or commonly in the IgG4 population, a different medication, rituximab, a different medication for those who have solid organ transplant called tacrolimus. So we're talking about tacro, for lack of a better term, rituximab, and Humira. Those are all immunosuppressants which act in a different way. And because of that, someone might need to follow different diet restrictions. In terms of like an organ transplant, someone who's immunocompromised, I would recommend avoidance of fermented foods just because if the risks go bad, if someone has increased risks for, let's say, foodborne illness, and they're at risk for losing an organ they desperately need that they had to get transplanted, the risks are very high, so I would avoid them. Dr. Stone, what do you think about rituximab and fermented foods?
For B-cell depletion, these patients are typically less immunosuppressed than transplant patient, for
Mhm.
example. So I would certainly, even for healthy individuals, I would not recommend unpasteurized milk, unpasteurized cheeses. But for patients who have undergone B-cell depletion to treat their IgG4-related disease, I wouldn't discourage them from fermented foods like kimchi or uncooked vegetables. I think they'd be fine as long as they're washed.
Exactly. And I look at that as basic, like safe food handling practices. I would
Right.
encourage everyone, whether they're immunocompromised or not, just to kind of follow healthy and safe food practices in terms of washing your fruits and vegetables and not eating too much undercooked proteins. These are all increasing the risks of foodborne illness. Um, so is the risk worth the benefits? Number one, it depends on what type of immunocompromised state you're in. For example, if you had a liver transplant and you're on tacrolimus, I would avoid fermented foods. But if you're on Humira or rituximab, like Dr. Stone was saying, you probably could have these and be totally fine. If you've been
Right.
told you're neutropenic, I would limit these kind of fermented foods. Um, but getting a little specific here.
Yeah, and neutropenia is not typically an issue with drugs used to treat IgG4-related disease.
which is a
We have
win-win.
several more good questions. It would be great to get through them, probably three or four.
Yeah.
So due to significant weight loss, about 20 kilograms, so that's
Mhm.
45 pounds,
Over 40 pounds. Yeah.
right? I started taking a supplement which provides calories, 18 grams of protein and fats in line with dietary recommendations. It's also a source of fiber and vitamins and minerals. The patient notes that I don't have steatorrhea, but rather am constipated with a low fecal elastase, so
Mhm.
EPI. I
Mhm.
take pancreatic enzymes and am on an oral hypoglycemic agent for diabetes. Is it possible to suspend the supplement, perhaps not permanently, or do I need to take the supplement continuously? Can
Yeah.
supplements be taken discontinuously?
I look at this. I'm not familiar with this product, but if it is essentially an oral nutrition supplement or a form of a shake, like an Ensure, a Boost, a Muscle Milk, what have you, it really depends on if you need it or not. And by that I mean if you're having trouble eating enough during the day, and like you said, this person has been losing a lot of weight, this supplement can be very helpful throughout the day, maybe even taking multiple in between your meals to kind of help fill in the gaps of your nutrition, specifically your calories and protein that could have contributed to your weight loss. I would say as long as it's not causing any adverse GI signs and symptoms, you should be okay to continue taking it. I would say I would not replace a meal with this sort of supplement. The goal of these is to supplement a meal. If you're only having liquids like this, you're kind of missing out on number one, the enjoyment or the variety of food. Um, but secondarily, it's supposed to add on to whatever meal you're taking, not fully replace.
Okay. Are there any special considerations for IgG4-related disease patients who also have diabetes?
Yeah, I think back to the slides and the topics we were talking about earlier. It's really number one about monitoring in terms of your hemoglobin A1C, that 3 month number. Weight control can be very helpful too. Um, Dr. Stone was mentioning earlier, someone having unintentional weight loss might have improved glucose tolerance. If you're having unintentional weight loss, it's kind of the wrong or less preferred way to do it. But if you kind of intentionally you're changing your diet, you're exercising more, and you can have intentional weight loss at a controlled, safe pace. If you're obese or overweight, kind of getting closer to a normal BMI or normal weight range. For example, if you're obese class 3 and you can get down to an overweight status, any improvement in intentional weight loss can be helpful. Additionally, working with endocrinology and a dietitian can go a long way. You're kind of not you're not at it alone.
I can't underscore that enough. I think most rheumatologists and gastroenterologists are really not up to date on the cutting edge issues in managing diabetes. It's very helpful to get an endocrinologist involved and a dietitian. Should I avoid foods that cause inflammation?
I think I'm going to frame this question as similar to what I said before. That foods have pro-inflammatory or anti-inflammatory properties, and it's just really hard to say that avoiding certain foods will reduce your inflammation. It's really hard to measure. For example, something that is really easy to measure is if someone has diabetes and they're insulin dependent, taking a certain amount of carbohydrate will induce hyperglycemia to some extent. There will be a cause and effect relationship, but in terms of inflammation, it's hard to measure it. So, with that being said, I would encourage more nutritious foods. That's one way to quote unquote reduce inflammation. I don't know if it makes sense to fully avoid certain foods and never eat them again. Again, we all are human. We all have eating is very social, and indulging from time to time is perfectly fine. Again, we're all human. But if your diet is primarily processed foods with a lot of saturated fat or included added sugar, those are just the types of foods that have more pro-inflammatory properties than anti-inflammatory. That just you might not be doing yourself the favor and replacing them more with that more nutritious, well balanced. I'm thinking back to that my plate in terms of the proportions and slides prior that outline amounts of food. I think that's the best way and the most reasonable way to kind of help modulate the inflammation that you're getting from the food.
Okay, great. This is fabulous content and information. Let's see if we can wrap up in the next 5 minutes.
Yeah.
So, for a patient with EPI, for the same number of creons or PERT pills in a meal and the same amount of fat, 10 to 15 grams, is it better to take the fat-soluble vitamin, A, D, E, and K, in a smaller or larger volume calorie meal? Maybe
Yeah.
you can sort of retranslate that question.
Yeah, and if you can go to the next slide, I think it might be. I'm
Okay.
going to combine these two questions together. This
Oh,
question
great.
was, do you recommend any supplements for IgG4 related diseases?
Oh, great. Yeah.
So the prior question was asking about those fat soluble vitamins. So someone with exocrine insufficiency is at risk. I, it really depends on if you're deficient. And deficiency is rare in those fat soluble vitamins. It's recommended to get all of them checked on the list on the prior slide to see if you're deficient. I don't know if it makes sense to take specific targeted doses of vitamin A and vitamin E and vitamin K just because someone has EPI. A daily multivitamin and mineral can go a long way. I would only take specific doses if you're deficient, but in terms of taking the dose taking the supplement with a higher or lower fat meal, as long as your enzymes are therapeutically dosed, meaning you're tolerating and you're not having any adverse signs or symptoms, I don't think it matters too much as long as you're taking enough of the enzymes.
Okay, great. So I think this is the last question.
Mhm.
It's primarily intended for me, I think. I have severe IgG4 related disease. Last year, I had 2 spine surgeries and 1 brain surgery necessitated by
Oh,
severe inflammation. I did a full year of chemotherapy via infusion, so probably B cell depletion, although B cell depletion is not chemotherapy, which didn't work. Now, in my second year, I'm receiving chemotherapy by taking pills. Maybe this is cyclophosphamide. I'm not sure. I would like to know if my diet has anything to do with it. So this is a very important question, and I'm grateful to the listener for including it. It helps us make the point that there are many patients with IgG4-related disease in whom dietary considerations are very, very important. Pancreatic disease, kidney disease, bile duct disease, and severe major salivary gland involvement. Dietary issues are paramount in the management of those patients and helping these people live normal lives. There are others where diet plays a less important role, and sometimes it is very important simply to think very creatively about the treatment approach. So I've shown this anecdote before. But this is a patient whose case illustrates this need to be creative sometimes. The patient is a 78-year-old woman with pachymeningitis, inflammation of the meninges area around the brain here. She was going blind because the meningeal inflammation was surrounding her optic nerves and choking them off. She was unable to walk by herself and had to walk with a walker, and this MRI shows inflammation of cranial nerves as they're coming out the base of the brain. So we had tried to treat this patient with peripheral B cell depletion. It worked for a while. Ultimately, it stopped working. We collaborated with neuro-oncology, neurosurgery, to create a way to instill the B cell depletion agent into her lateral ventricles by forming what's called an Ommaya reservoir that the neurosurgeons had to do. And this woman went from falling and breaking her hip before the procedure to this afterwards, after we had treated her a couple of times with B cell depletion in her intrathecal therapy, it's called. Watch her walk now. Previously, she had only been able to walk with a walker. Watch her walk and turn. Perfect. This is my voice you'll hear.
Okay, you can turn around.
Look at that turn. She was
Mhm.
previously able to walk only with a walker. So this is a great one to end on. I want to thank Kevin Walton for a wonderful session and educating us about the critical role of registered dietitians and nutritionists in the management of patients with IgG4-related disease and people living with this disease. You'll be able to see reruns of this next week on our website. I am sure you're going to see this in smaller aliquots in various educational sessions that we have. If you have additional questions for us, particularly for Kevin, please feel free to submit them through our website. And I remind you about our surveys. There's a survey right after this fireside chat, which we ask you to complete. It's only got 3 short questions. And then the survey that we sent out earlier this week, 8 to 10 questions. We would love to get your detailed input on that. So thank you very much for joining us today. Look forward to seeing you again soon. Thank you, Kevin.
Yeah, thanks so much, Dr. Stone, for having me, and thank you for the foundation.